dysfunction. And actually, as it turns out, the pituitary dysfunction can last for a long period of time. In fact, there are some people in my field that say once you have hypopituitarism, you always do. But these are two studies in particular, one from my colleague, Tamara Bushnick, who's now at the Rusk Institute with me, showing that these abnormalities can last upwards to 10 years and probably more. And what they're finding also, and these two studies are worth noting, that growth hormone deficiency in particular is very, very common, and we'll see why that is potentially problematic later on, and that in many cases it's not just one axis within the pituitary endocrine function that's abnormal, it's sometimes two or even more than two. So it really is quite significant. These are just some studies looking at some of the adverse impact or some of the problems that are associated with some of these endocrine abnormalities. For instance, here in the Popovic study, neuropsychological testing, psychiatric testing associated with growth hormone levels and so forth. So having, and this and it just goes on, as you can see, abnormalities in body composition and lipid profile, abnormalities or worse outcomes in the GOS and what have you, associated with endocrine abnormalities. Now, there's not necessarily a cause and effect here, but there is this strong association. And some of the adverse effects of impaired growth hormone, and growth hormone really does seem to be impaired with traumatic brain injury, include altered body composition. How many of your patients with TBI say to you, I know they say to me, Doc, I'm just, I'm getting fatter and fatter, but I'm not eating anymore. Depression, they have lipid abnormalities. They all complain of fatigue. One of my colleagues did an excellent study looking at insulin-like growth factor, which is a marker of growth hormone activity, and there was a direct correlation between abnormalities in insulin-like growth factor and levels of fatigue. Quality of life is impaired. Sleep abnormalities, cognitive performance. One of my colleagues down at the University of Texas is looking at replacing hormones in individuals with endocrine abnormalities, and he's actually finding, in preliminary studies at least, and it hasn't been reported yet, that cognition is actually improving as he's replacing growth hormone. So there really is something here, at least I believe it to be true. Suggested testing has been recommended. This is from an article in Brain Injury 2005. If you have the handout, you can certainly look at this, but basically in the acute rehabilitation setting, folks should be evaluated either in the ICU or once they get to rehab, and or if you see patients for the first time as an outpatient, then basically at the first time you see them. And we're looking to do morning samples of serum cortisol, thyroid functions, insulin-like growth factor, FSH, LH, prolactin, cortisol, urinary cortisol, and so forth. Predominantly functions, except for the polyuria test, functions of the anterior pituitary gland. So again, I would encourage folks who are treating individuals with traumatic brain injury to take a serious look at this. Again, you see what you look for what you know. If you don't know to test for pituitary dysfunction, you will never pick this up. Going on to orthopedic complications, heterotopic ossification really is the only one I'm going to talk about. And HO is, simply put, bone where bone doesn't belong. And there's an increased incidence in any type of central nervous system abnormality, including stroke and spinal cord injury, but it's certainly true for TBI. And you can see here again the arrow sign. I'm not sure how well it shows up there, but you can see all of this fuzzy stuff over here around this patient's hip, and that is all ectopic bone. It doesn't belong there. And you can imagine this is going to ankylose that hip. That hip is going to be stuck in this position. Try walking with a hip that doesn't move. It isn't so easy. It can involve other joints as well, and in traumatic brain injury, the hip, the shoulder, and the elbow are very commonly affected, as well as the knee as well. In my experience, the knee is not as common as some of these other ones, but you can see it. And we also think, for those who treat folks with TBI, if you ever notice they have a fracture and they get that tremendous excessive callus formation, very, very common. And we suspect actually that excessive callus formation over the area of a bony fracture actually may be a form of heterotopic ossification. What causes it? We really don't know. The best we can surmise is that there's some sort of inducing agent that causes fairly undifferentiated mesenchymal cells to take on the characteristics of osteoblasts that lay down this bony matrix that ultimately becomes calcified. The clinical presentation, it can be dramatic when you see it. The limb can be swollen, warm, and red, which means, of course, you have to make sure that you're not dealing with infection or a venous thrombosis or undiagnosed fracture. Oftentimes in the rehab setting, we actually are diagnosing trauma that was missed by the trauma team. Not that the trauma team has, been negligent in overlooking anything, but they saved somebody's life and they're comatose, and the patient didn't start complaining of pain because of a broken fibula until they, tried to stand up. Diagnosis, be careful with radiographs acutely. When someone first develops symptoms and you get x-rays, those x-rays are likely not to show that heterotopic bone. So for that reason, at least acutely, radionucleotide bone scanning is the preferred test, and because it is positive once symptoms start to, or clinical signs appear. The treatment, once it has been diagnosed, not terribly effective, I have to be honest with you. Adidronate sodium has actually been shown to be effective as a prophylactic means. I don't think it's ever been shown in traumatic brain injury, at least, to be terribly effective once actually it has been established. There was some thought that a range of motion done by therapists in the acute rehab setting was a cause of HO. I assure you that's not the case. It's just that heterotopic ossification shows up, at about the time folks are admitted to rehabilitation. So for all you physical therapists out there, don't worry, you have not caused heterotopic ossification in your patients. We do use nonsteroidal anti-inflammatory drugs, particularly indomethacin, may be helpful certainly with pain. And radiation is really a good prophylactic measure, but not very good once the HO has already been established. Surgical resection is somewhat controversial. I feel, and this is my own opinion, that resecting heterotopic bone is the way to go if function is impaired. And my belief is that it should be done earlier rather than later. In the past, it was recommended that a bone not be resected for at least 18 months or until the bone is, quote, mature on bone scan. My argument against that is leaving an elbow stuck in this position for a year and a half is not very functional, and trying to rehabilitate somebody even after resection when all the muscles and all the vasculature have shortened, good luck, is all I can tell you. So I'm a proponent, whenever I can get an orthopedic surgeon to agree to do this, is to resect bone early if in fact it is impeding the rehabilitation process or function is impaired. These folks should get radiation before and after the resection, and of course once the resection is done, put them on adidronate sodium or indomethacin immediately afterwards to try to prevent that bone from growing back. And there actually are cases reports, again it's anecdotal I realize, that those methods, pre and post surgical radiation and adidronate sodium, are effective in preventing reoccurrence. So I feel get it done earlier rather than later. Cranial nerve dysfunction. I love reading the history and physical examinations of my colleagues, and when it gets time to the neurological evaluation or assessment, I always see cranial nerves 2 through 12 intact. Poor cranial nerve number 1. It's neglected, and as it turns out, one of the most common, if not the most commonly affected cranial nerves after traumatic brain injury. It's so susceptible to trauma as the olfactory nerve passes the cribriform plate up until the olfactory bulb in the brain. So it's very commonly affected, but I think very few of my colleagues, at least, ask my patients, how is your sense of smell, nor do they test it. Or if they test it, they probably test it incorrectly. As it turns out, what my patients tend to complain about, some of them complain about not being able to smell, but often they complain about not being able to taste. Now, your sense of taste actually is controlled by several cranial nerves. But I remember as a kid when my mother made liver, which was the worst thing possible that she could ever make. I would eat it holding my nose because you can't taste what you can't smell. So when folks lose their sense of smell, they often complain of not being able to taste things as well. So, and also you have to make sure that you're testing for it properly. So, I love asking my residents this question. So, make sure you go test, Mr. Jones's sense of smell, and they get out the ammonia bottle. It's like, oh yeah, their sense of smell is perfectly intact. They were completely turned off by the smell of ammonia. Something that's really noxious like that is actually going to stimulate cranial nerve number 5. So you have to be very careful to make sure that you're using something that's aromatic, like coffee grounds or something like that, that's meant to stimulate cranial nerve number 1 and nothing else. So you have to be careful how you test it. Oftentimes, not always, the impairment may be transient. If the nerve hasn't been completely severed, it does have some regenerative capacity. But there's no real treatment for this, at least certainly none that I'm aware of, except that I think we have to make sure that we're educating our patients from a safety perspective. Make sure that food in the refrigerator is properly labeled. You date it. It's been in the refrigerator 3 weeks because they can't smell it. They're not going to say that it smells bad. So date it and make sure they're throwing it out. They have to make sure that they can't smell their shirt and make sure it's clean. They have to make sure that their clothes are cleaned on a regular basis. Make sure that their smoke detectors are working properly, because they may not be able to smell smoke and what have you. So it's really predominantly education more than anything else. I'm not going to spend too much time on seizures since we talked about it before, but I already mentioned that prophylaxis is probably not necessary for preventing late post-traumatic seizures if your patient has not had a seizure. It is important to know, however, and we didn't talk about this, that uncontrolled seizures actually is a significant risk factor for early mortality. So certainly if your patient has seizures, you must treat them, and you must treat them effectively. But all of the anticonvulsants do have adverse effects, and they have adverse effects on cognition and arousal, the very problem that these folks are coming to us with in the first place. So we only want to give them anticonvulsants if there's a real indication for it. So we have to be cautious about them. And actually, in this slide, this came from Nancy Temkin. She wrote a very nice review earlier this year. And if you take a look at this, it's particularly this line right here, for late seizures, most of the medications here, with the exception of the combination dilantin and phenobarbital, actually were not effective, at least in group settings, with regards to reducing seizures. In fact, it almost had a pro-epileptogenic effect. And although in this one study, and actually it turned out to be, I think, more of a, it wasn't a very solid study, but it was a combination of dilantin, phenytoin rather, and phenobarbital. That was effective, but again, phenobarbital, not exactly the drug that we want to be using to treat seizures. Now, in any one individual, phenytoin may be effective, valproic acid may be effective, and of course, you need to prevent seizures. But at least as a group, they appear not to be terribly effective. And so I mentioned this before. Again, recommendation is to prophylax for the first week, but routine prophylaxis thereafter is not indicated unless your patient has had a seizure. I didn't talk about aggression this morning, and it's my favorite topic because I remember when I first started in this field, and I would come to my inpatient setting, and we had a new patient waiting, and oftentimes it was a young man who physically wasn't too impaired, but cognitive and behaviorally very impaired, and the nurses would run to me, Dr. Flanagan, what drug are you going to give this patient? Quick, make them quiet. Because, it's kind of scary. I've been slapped across the face. My glasses have gone flying across the room. I've had patients, set their mattresses on fire. Egad. The list goes on and on and on. But before we throw drugs at our patients, it's really important to try to understand why they're agitated, and perhaps we should address some environmental and behavioral issues before we start throwing drugs. So, for the parents in the room, I'm sure you remember when your children were infants and they were uncomfortable. What did they do? They would kind of squirm and cry, and in the brain injury world, we would call that agitated. When in fact they're really just uncomfortable and they have no other way of expressing it. Certainly our patients who are emerging from coma or who really can't express themselves well may express their discomfort in an agitated way. So is there pain? Is there an undiagnosed trauma that we should be addressing? I remember having a patient come to me with an anoxic brain injury from overseas, and the doctors did a wonderful job, and all of the healthcare team did a wonderful job in saving this man's life. But the one thing that they failed to notice in the 3 weeks they were under his care, that he hadn't had a single bowel movement. Now, I guarantee you, anybody in this room who's been constipated for the past 3 weeks would be agitated. So was this man. So the medication we gave him was either an enema or milk of magnesia, whatever it was, and he calmed down. Is there an infection, a urinary tract infection? Is there some low-level hypoxia? We found that in one of our patients, a little nasal cannula O2 calmed him down. I touched base a little bit this morning about how impaired cognition may also result in an agitation. So again, imagine yourself waking up in a room and you think you are perfectly fine, a typical scenario, someone with traumatic brain injury who has no awareness. You want to leave the room, the guard outside of your room says, no, you have to stay here, you're ill. What do you mean I'm ill? I'm perfectly fine. And you can imagine sort of ratcheting that up. So, we seem to need to, reorient our patients, memory boards, orientation boards, things like that, and maybe even give medications to improve cognition, as we talked about in my last lecture. You also have to be careful, particularly as our patients are emerging from coma, not to give too much stimulation. I remember, again, early on in my career, it's around Christmas time, and as I'm making bedside rounds and getting closer and closer to this patient's room, I hear the agitation growing and growing, and he's so restless, and the nurses are saying, oh, Dr. Flanagan, you got to do something, you got to do something. As I walk into his room, God bless this man, his mother had decorated his room for Christmas, and in the United States, it's blinking lights and garland, and I think there was one of these animated Santas going back and forth singing White Christmas. It was just way too much stimulation for this poor guy. So I'm not sure if there's a Christmas special in the United States called How the Grinch Stole Christmas. So I was the Grinch that year, and I took down all of the Christmas decorations, but my patient calmed down. So oftentimes we just have to be careful about the excessive stimulation that we provide our patients, because that may be all we need to do to bring down the agitation. Some other environmental interventions, make sure that, wherever we're asking them to do, I have cognitive demands here, but even physical demands, at some level meet their ability. To stress them too much or give them demands that that they just can't meet at this level of their recovery will simply cause agitation and frustration. Make sure that we're providing structure, doing basically the same thing every day so that the patients aren't so confused by day-to-day changes in their schedule. Memory books, orientation boards, family pictures are really very important in the room for folks as they're getting over that period of post-traumatic amnesia. We need to educate family and loved ones not to have everybody pack into the room and start talking all at once. Folks, as they're emerging from coma, one person talking at a time. If you are talking, the TV's off, the radio's off, very important. And of course, we provide our rehabilitation in a non-distracting environment whenever we can. But there are times when, in fact, we do need to give medications to control behavior. Among the best studied, although not among my favorites, are beta blockers. Beta blockers have been shown in some studies to decrease either the intensity or the frequency of agitated behavior. In my experience, I think that they tend to work best in sort of the slowly progressive escalation and agitation. As I said in my first lecture this afternoon, if I do use a beta blocker, I do like like to use those that are hydrophilic, that is, they don't get into the central nervous system. I like using the something like Nadolol, because I think that basically it works, at least this is my impression, by sort of calming down the periphery. It, prevents your heart from getting really fast and prevents your mouth from getting dry, so it sort of calms you down that way. I believe it works probably the same way that it works to help people who have stage fright, who take a beta blocker before they get on stage. So it can be effective, and there's some evidence to suggest that they are. Now, of course, I just told you that I try not to use anticonvulsants, but in some cases where agitation is a big problem, I have found, particularly when it's explosive rage, things like carbamazepine or valproic acid, I found in my experience to be effective. And sometimes even in low dosages. If we think that some of the agitation may be brought on by impaired cognition, perhaps some of the dopaminergic agonists may be helpful. And one of my colleagues down at at the Carolinas Rehab actually has completed a pilot study on amantadine for just irritability, low-level irritability, and appeared to be effective. And she's now studying this in a multi-center, double-blind, placebo-controlled manner. So I'm looking forward for that to come out. Some of the novel or the newer antipsychotics, although they have some metabolic abnormalities that you have to be careful for, probably are okay in select cases if you really need to control the agitation. But all of these medications are not given in isolation, meaning that you still have to provide the environmental and the behavioral modifications. The medications themselves are just not a panacea. They're not going to fix everything. And that approach of behavioral and environmental modification is one that's done by all the rehabilitation team members and the families. The families really need to be educated on how you're trying to control the agitation and get their buy-in. What we like to do is to avoid the traditional neuroleptics, the haloperidols, the thorazines, the melorils, etc. They lower seizure threshold, they impair cognition, they impair motor recovery, they can have the extrapyramidal effects, and although rare, you can see, I haven't seen it myself because I hardly use them, you can see neuroleptic malignant syndrome, and that can be in the unknowing eye of a young intern or resident being misdiagnosed as sepsis. So, we try to avoid them, and sometimes you have to use them, certainly for safety cases, if no patient or patient safety is being threatened. But by and large, I think that you can avoid them in most cases. Moving on to hydrocephalus, I think most of the folks here in the audience know about this. For regards to normal pressure hydrocephalus, you know the classic triad of urinary incontinence and impaired cognition and ataxia. But in the rehab setting, really what I see more than anything else is just folks just don't progress as you expect they should be. They seem to be doing well, and then they either plateau or seem to go downhill. And of course, when someone declines, you have to rule out all the other things. Sepsis, infections, metabolic abnormalities, but do suspect hydrocephalus, particularly if they've had a history of subarachnoid hemorrhage or intraventricular hemorrhage or perhaps even meningitis, because that will increase the risk of hydrocephalus. Because once you do treat the hydrocephalus, if it's there, you can see a dramatic turnaround and improvement in your patients. Diagnosis, you probably know, predominantly through neuroimaging, you see enlarged ventricles out of proportion to the sulci. So here, large ventricles, the sulci basically being effaced. And you also see the periventricular edema as well, all signs of hydrocephalus. I will say that for those in the audience who do treat this, sometimes the findings on neuroimaging tests are less than overwhelming. In those cases, we may do a CSF tap test where we'll just do a high volume CSF tap on our patients, get out 30, 40, 50, sometimes even 60 cc's of CSF. It's a lot of fluid. Of course, we make sure that we get a scan first just to make sure there's no big lesion there. And in fact, I have seen some improvements predominantly in gait in some folks, and those are the people we tend to send for shunting, and they tend to do well. boy, this is a tough topic at 4 o'clock on a Friday, 5:30 on a Friday afternoon. Hyponatremia, how exciting is that? Boy, try to calm yourself down on this one. The reason I put this here is that I remember as a young intern, whenever anybody had low sodium, it would just be a knee-jerk reaction. It's a syndrome of inappropriate ADH secretion, start restricting fluids. But in fact, not all hyponatremia is SIADH, and there is something called cerebral salt wasting. For those of you who are not familiar with it, it's actually almost the polar opposite of SIADH, whereas in SIADH, folks are typically euvolemic. In cerebral salt wasting, what's happening is sodium is being lost in the urine, and of course where salt goes, sodium goes, water will follow, and what happens is that you have a clinical situation of dehydration, high urine sodium, so the last thing you want to do when someone's dehydrated is to fluid restrict them. So when you do have cerebral salt wasting, and it's not such an easy diagnosis to make, but you do have to look at other evidence for dehydration and what have you, but this is treated in the exact opposite way of SIADH. You give fluid and you give salt replacement. And for folks who've had particularly subarachnoid hemorrhages, restricting their fluids and worsening their dehydration can actually worsen their neurological status by potentially increasing your risk of vasospasm. So just be careful and just don't do that knee-jerk restrict fluids. It would be inappropriate of me not to address sleep and fatigue after a traumatic brain injury. For those of you who treat people with TBI, boy, particularly acutely, what a challenge it is. They sleep all day long and they're up all night long. The nurses just love it. So we get this reversal of a sleep pattern, and even if they do have, they don't have that reversal, so many of them complain of problems with insomnia, either falling asleep initially or staying asleep once they do fall asleep. And one of the biggest problems my patients complain about is that, yes, I do sleep, doc, but I wake up feeling as though I didn't sleep at all. So it's actually a big problem. One thing I will urge you to do, though, is to get some type of collaborative data, if you will. People, and I will tell you, even folks here in this audience right now, are not accurate reporters of their sleeping patterns, and we know this. I have patients come to me all the time saying, Doc, I haven't slept, more than 1 hour in the past 5 years. Now, first of all, I think that's physiologically impossible, but I will tell you that I will send these people for polysomnography, and in fact, I get these reports back, and they slept solidly 8 hours, and it's 8 hours in a completely unfamiliar environment with, these things on their head for EEG recordings and a pulse oximeter. If ever there was an artificial way of keeping somebody awake, it would be a sleep lab. So you have to be careful in realizing that people may not be accurate reporters. So ask spouses, ask nurses, were they sleeping or were they not? Again, before we give medications, I think it's important to promote sleep hygiene. It's so easy to prescribe a pill. It's harder to do some of these other things. But what I like to tell my patients is make sure that the environment in which you're sleeping is non-distracting. It's quiet, the lights are out, and what have you. I also tell them that your bed is for sleep. It's not for watching TV. It's not for reading. It's not for eating, because I want them to associate their bed with the place where they're going to go to sleep, not with some place where they're going to be reading or watching TV or eating a late night snack or what have you. I also suggest to them that if you can't fall asleep within the first 30 minutes or so, try sleeping someplace else, somewhere else in the house where it's quiet, or just getting up and doing something that's relaxing, doing some little light reading or watching TV. And I'm not saying some horror movie that's going to get you all excited, but something nice and quiet, listen to some music, and then maybe go to bed again in about another 30 or 40 minutes and see if that helps. The same thing if they're waking up in the middle of the night and they can't get back to sleep again, to do the very same thing. And sometimes that is enough to help. If we do need to give them a sleep medication, and oftentimes we do, again, I like to avoid the benzodiazepines, the Ativans and the Valiums or what have you. I will say that most folks in the United States who do brain injury work, at least the ones that I consider that I work with a lot, use trazodone. It's not a great antidepressant, but it is a pretty good sleeping sleeping pill. And believe it or not, in the United States, it's one of the leading sleeping pills prescribed, which is sort of interesting because it's not actually approved for that. A fairly new drug out, Ramelteon. It actually acts on the melatonin receptors. Approved for long-term use. It's not habituating, so it's nice. You don't have rebound effects if you stop it all at once. Mirtazapine, another antidepressant. If you do give this to your patients for sleep, you just need to tell them, well, first of all, of course you give it to them at night, even if you're giving it to them for depression, but they may have a little hangover effect the next day, so you just have to be careful with that, but that's usually short-lived. We talked a little bit about the Z drugs, the zolpidem, zolaplan, zoplicone, and although not beginning with the Z, ezoplicone, all drugs that are available. Ezoplicone actually is approved for long-term use. It's even though it acts on the benzodiazepine receptors, appears not to be habituating. So these are the medications that we use. Basically, take your pick, whatever works. Although I will say that trazodone is one that we use quite often. And with that, that leaves us, yeah, that's my issues. I really need to get another picture. She's actually a grown dog now. She's 6 years old, but it's such a cute picture. I had to keep using it. And don't be fooled by that sweet face. This dog was a terrorist growing up, but she's very sweet now. I gave you a lot of information, so please feel free to ask me some questions. Yes, in the back.
Thank you. Just a comment on your experience with dantrolene for long-term use, just because it's used for malignant syndrome, which you mentioned.
Yeah, malignant neuroleptic malignant syndrome, right.
Yeah, thank you.
Yeah. So one of the things you need to be cautious with dantrolene, particularly in women as they get a little bit older, is liver dysfunction. So you do have to keep your eye on that. I have not had that experience, partly because I don't use it that often. The one nice thing about it is that theoretically it acts at the periphery and not in the central nervous system. So you think it wouldn't have an effect on arousal, but quite frankly, it does. The other thing that you have to look for is that it's not necessarily selective for spastic muscles, so it can make sort of normal muscles weak as well. So I tend not to use it very much, partly because, again, I sort of bend the rules a little bit. If I see someone who's spastic, after traumatic brain injury at least, I'll tend to go either for the toxin injection earlier on if it's fairly localized spasticity, or if it's fairly widespread, I tend to go a little bit earlier with the intrathecal baclofen, simply because it's just my experience that these drugs are just not well tolerated. The fatigue that my patients have before these drugs go on is so limiting that anything that I give them that makes that worse is just intolerable. But there are a few instances where I have used dantrolene. I watch liver function very closely for the first several months, and then periodically thereafter. And in some cases it works, but in all honesty, I just don't use it that much.
Is it labeled for spasticity in the States?
It's indicated. Is that what you asked for? Is it indicated? Yes, it's indicated for spasticity in the United States. I'm 99.9% sure of that. It would not be an off-label use.
So, thank you very much, Professor Flanagan.
Thank you.
Professor North, thank you very much.
This is my fourth visit to Greece, so I'm going to ask a Greek direct question. Politely. Tomorrow we have in the morning 4 very interesting lectures by Professor Frigatano and Professor Wilson. They will give each one a different lecture in the morning. I'm not asking you to tell me who is planning to be here, but if you are planning to be here tomorrow, make sure you are here at 8:30. We don't want to waste a lot of time. Okay. Now forgive me. How do you say forgive me